Good morning, afternoon, and evening to you all. To those joining us live and to those listening in afterward. Welcome to 19 episodes of FIP's digital program on the development goals, setting goals for the decades ahead. Today's episode is about FIP Development Goal 17, Antimicrobial Stewardship. Let me first introduce myself. My name is Virat Thonglod. I'm now a Vice President of the Pharmaceutical Association of Thailand under Royal Patronage, and to be a lecturer at the Faculty of Pharmaceutical Science, หัวเฉียวเฉลิมพระเกียรติ University. And let my co-moderator introduce herself. Are you Deji? Let you.
Hello everyone, my name is Ayodeji Matsuduko. I'm the co-moderator for today. I'm a PhD student at Glasgow Caledonian University. I'm from Nigeria, and it's nice to have everyone here today.
Thank you, Ayodeji. Before we begin, we'd like to share some housekeeping announcement with you. This webinar is being recorded and live streamed by YouTube. The record will be available on our website, worldwideweb.fip.org. You may ask questions using the question box provided. You are welcome to provide feedback to webinar at fip.org. If you want to become our member of FIP at worldwideweb.fip.org/membership registration. Let's begin by briefly introduce you to this digital program, setting goals for the decade ahead. Setting goals for the decade ahead is FIP's 221 digital program on the FIP Development Goals. It's a comprehensive online event series which provides coverage of 21 goals over 21 events in 221. The 21 events run between March and September of this year, with an average of about 2 events per month, and a particularly busy in September, which coincides with World Pharmacy Weeks and World Pharmacist Day. You can register to all events by visit event.fip.org. We encourage you to do so, and we look forward to having you in our upcoming episodes. The expected outcomes of the event are: first, describe the FIP development goals and explain the components of the development goal 17 and its key component or element: workforce, education, science, and practice. Showcase the FIP tools, evidence, and resources to support DG 17 implementation across the key elements. Third, identify priority across practice, science, and workforce and education within Development Goal 17. Fourth, engage our members in an activity to support monitoring and education of goals through data evidence. Let Ayodeji to introduce speaker.
Thank you very much, Dr. Wairat. So I'll be introducing our speakers for today. We have 4 speakers, and our first speaker is Professor Katia. She holds an integrated master's in pharmaceutical sciences from the Faculty of Pharmacy, University of Lisbon, and she has an MSc in clinical microbiology from the same university, as well as a PhD in health sciences and technologies, specializing in microbiology. She's a coordinator of the Microbiology Research Laboratory in Environmental Health at the University of Lisbon, and she's also an invited professor at the same faculty. She's also been elected a representative of the Infectious Diseases Working Committee of the Portuguese Society of Pneumology. She's also an health home care business and scientific director of a company. She has more than 10 years research experience in the area of AMR, antimicrobial resistance, especially in the epidemiology of healthcare-associated infections caused by gram-negative bacteria. She currently serves as a member of the FIP Commission on Antimicrobial Resistance, and she's going to be speaking today on the first part of the component of the Workforce Development Goal 17. FIP DG 17 on AMS. Our next speaker is Ms. Chin Yen Yu. She's a hospital pharmacist with a particular interest in antimicrobial stewardship, infectious diseases, health system strengthening, and global health. She has over 10 years of experience as a registered pharmacist in both hospital and community settings in Australia. And she's also completing her MPH at the University of New South Wales, specializing in infectious diseases control and epidemiology. In her current role as a senior antimicrobial stewardship pharmacist, she provides strategic leadership direction and expert advice to the hospital clinicians and administrators in the implementation and evaluation of the antimicrobial stewardship program across Western Sydney local health districts. Our research interests include consumer and patient partnerships in antimicrobial stewardship. She's also actively involved in various committees of the Society of Hospital Pharmacists of Australia, including the New South Wales Branch Education Subcommittee and the Federal Education Steering Group. She continues to advocate for the pharmacy profession as a member of the FIP AMR Commission. Our next speaker is Dr. Merfin. Dr. Merfin Mpudu is the director of REACT Action on Antibiotic Resistance Africa, where he is responsible for strategic leadership in implementing REACT's strategic plan and activities in Africa, focused on AMR national action plans development and implementation and regional strategies. He's also responsible for building partnerships with other stakeholders, including governments, supporting translation of evidence into policies, and contributing to regional and global governance and catalyzing action to address AMR. He's also the Partnerships and Stakeholder Engagement Lead for the International Center for Antimicrobial Resistance Solutions, ICAS, that is responsible for Africa supporting ICAS's engagement with countries and supporting demonstration in implementation and intervention research to address AMR. He's a public health specialist with over 20 years of extensive experience in global health policy, health system strengthening for pharmaceuticals and health technologies, pharmaceutical supply chain management, pooled recruit procurement, global health security, conceptualizing and developing innovative, sustainable health financing options for healthcare delivery and strategic development. He has successfully supported several countries with their AMR National Action Plan development and implementation, and he has led antimicrobial stewardship efforts, regional pharmaceutical commodity pooled procurement initiatives in West and East Africa, and has provided technical support to the WHO, FAO, OIE, Africa CDC, and Southern Africa Development Community, SADC, on AMR strategies and policies. Our next speaker is Dr. Dala Amuji. She's a registered pharmacist and holds master's and PhD degrees in pharmaceutical and biological sciences, specifically microbiology and infectious agents. She received her PhD in 2015 from the Faculty of Pharmacy, St. Joseph University, Beirut, Lebanon, in collaboration with Rodolph Meriel Laboratory, Beirut, and the Faculty of Pharmaceutical and Biological Sciences in Paris Descartes University. She's the Associate Dean for Assessment at the School of Pharmacy, Lebanese International University. Her research interests include antibiotic resistance, pharmacy practice, pharmacy education, and health awareness. Dr. Amudi is a member of FIP Women in Pharmacy Science and Education, FIP-WISE, since February 2020, and also is a member of the FIP AMR Commission, where she will lead the regional engagement of the Commission for the Eastern Mediterranean region. So I'll hand it over now to Dr. Wairat to continue introducing the next components of our webinar.
Maybe I let Merfin M. Pundu introduce yourself, please. Merfin M. Pundu. Okay, I will go on and let you introduce yourself in your section. Okay. Before we hear from our speaker, we want to quickly remind you of the FIP development goals. The FIP development goals was our launch in September 2020 as one FIP goals that bring together pharmaceutical practice, science, and workforce and education. As per our vision and mission, FIP believe that we can have no pharmaceutical care without a pharmaceutical workforce, and we can have no pharmaceutical care without a scientific foundation for the next decades. FIP use the same consensus-based approach to explain the goals into a set of 21, each reflecting elements of practice, science, and workforce and education. Let's watch the next short video to see the 21 goals in action. FIP Development Goal 17 calls for workforce and education strategies linked to the use of evidence-based development frameworks to support the translation of pharmaceutical practice, science and workforce, and education across all settings and according to the local and national needs. The goal calls to support professional career development by using tools such as the WHO AMR competency framework that FIP contribute to describing competencies and behaviors across all settings. The goal is composed of 3 elements: workforce and education, practice, and science. Our first speaker will introduce the workforce and education element. Let Katia give the floor to the first speaker, Katia.
Hello, I don't know if you already seen me.
Yes, I heard you.
Hello, everyone. Thank you for this invitation. It's a great honor to be here, to be part of this event and the EMR Commission. Thank you all for being here with us. On this first slide, I want to share with you the main aims of the workforce education element. We aim to develop strategies and systems in place to develop a pharmaceutical workforce prepared to deliver quality services for antimicrobial stewardship. And here is presented the main mechanisms that we can use. If you move to the next slide. Here we want to remember all of you that the antimicrobial stewardship programs are evidence-based and that already prove that can reduce the use of antibiotics and mostly to promote the rational use of these antibiotics. So here I show you some contents of training that the pharmacist should include on the training of antimicrobial stewardship programs. We need to know about the diagnostic, the antimicrobial susceptibility testing. We need to know the antibiotic guidelines, not only the international, the European, the region, the local guidelines, and to align them with the resistance traits, with the surveillance knowledge, because I remember that sometimes these antimicrobial traits are different between countries, between regions of the same country, and also between hospital and community, and sometimes even between wards of the same hospital. So we need to know these traits. We need to know about vaccines and therapeutics, because if we have vaccine available, it's quite important to promote it. To support the clinical choice and to evaluate the response, to know about the properties of antibiotics and its effects, to evaluate the trends of the consume, to promote the adherence, the compliance, to know about sanitation, disinfection, and all of that thematics, and know about the new antibiotics developments that, as we know, there are a few new antibiotics available, but we need to integrate all this knowledge because, for instance, the ceftazidime-avibactam new combination has different efficacy even with the enzyme that is produced by the same bacteria. So we need to be supported by the science and to development knowledge about all these thematics. I love the FIP development goals and how it can show us that we are not working alone. And development goal 17, the antimicrobial stewardship, is closely related with the academic capacity, with the training in different stages of our career. We have to be the expert on these medicines. Of course, if we talk about infections, we are connected with the communicable diseases, but we cannot forget the non-communicable diseases. As COPD, as you know, have a lot of exacerbations and have a lot of antibiotic use also. So we need to be people-centered, care-oriented, and of course, we speak about patient safety when we promote this good practice. It's a goal to development a competency on this area. Of course, the development of policy is of great relevance, and we need to work with others. And at this time, if we see the next slide, we see that for pharmacists, it's our life. We are used to communicate with the physicians, with the nurses, with the dentists, with general public, with the patients on the hospital and community. And of course, we need to integrate new skills as motivational, interview, communication skills, because in antimicrobial stewardship, we want also to improve the behavior of the patient, the behavior of the use of who use these antibiotics, and we also need to expand our scope of action, for instance, with veterinary, as you know, under One Health scope, and which is our environment. All of the known environments, because we can improve and we can implement these programs on hospital and community, on trying to change the behavior of the patient on their homes, and also, for instance, in long-term care facilities that, as you know, has a lot of antimicrobial resistance traits, and a lot of pharmacists working together with these healthcare facilities. So the adequate education and extensive training is key to perform an adequate antimicrobial stewardship program. On the next slide, we can see some of the FIP digital events of this year, and it's quite amazing to see that under a COVID pandemic, FIP is having a high contribution to increase the pharmacist knowledge and skills. So I want to public knowledge to FIP, to the staff, to the board, to all the panelists, and of course all of you that assist to these events, because when we talk about the sore throat, the disinfection, the medication adherence, the vaccination, patient safety, Sabiha was also talking about all these week events that we have on different regions, and next Tuesday the global event to accelerate antimicrobial resistance actions through antimicrobial stewardship. So it's quite amazing, and congratulations all for these events. Also between continents, for instance, all those countries that speak in Portuguese also have these events. So at the next slide, I want to share with you the challenge. From my perspective, the challenge is to integrate all these data, information, knowledge that we can provide you through training, through education, but what we want is to acquire expertise. So we need to establish the basis of the antimicrobial stewardship program, hopefully with a reference document, in which we can share the good practice, because there is already good practice between the worldwide pharmacists, and to promote or to allow you resources as guidelines, formularies, policies, and training. We want to develop a framework, competency frameworks, in order to have advanced expertise on this thematic. And at the final slide, remember that the science is the support to the workforce and to education. And in this element, we can train. Mostly we can empower and engage the pharmacists to implement in their practice these antimicrobial stewardship programs, and this experience will give us back new questions to the science and new needs to education. So I believe that the pharmacists are being prepared, plays a vital role, and only with the concerted efforts of all we can ensure the efficiency of antibiotics. Thank you very much.
Thank you, Katia. Our next two speakers will introduce the practice element. Let your Chin Yen and Murphy.
Hi.
Hi.
Hi. Thanks for the introduction, Virat. Sorry, Murphy and I will be presenting or discussing the practice element of the development goal number 17. Sorry, as you know, in terms of implementing the structures and frameworks of an antimicrobial stewardship program in hospitals, or it's very context specific. So I will be spending the next 5 minutes talking about implementation and the practice element of AMS in a developed country, and Murphy will explain the practice element in low to middle income countries. Next slide, please. So under the overarching practice element, there are 3 key mechanism statements. So the first is to develop and implement systems and structures to develop or to deliver, implement antimicrobial stewardship services as a systematic program which promotes the appropriate use of antimicrobials, and also to improve patient outcomes and decrease the spread of resistant organisms. And the next statement is to utilize and assess data and metrics to improve and optimize AMS services. And the third statement is to advocate for and support the responsible use of antimicrobials. And I'll briefly talk about the strategies that we apply in our practice. Next slide, please. So as you know, as Ayo had mentioned earlier during this presentation, this webinar, I am a hospital pharmacist by trade. Sorry. Is my audio a bit better now? Can you hear me better?
I can hear you.
You can hear me? Okay, great.
Yes.
Right.
Yes,
okay,
let you
thanks.
go on.
Right.
Thanks.
Okay. Sorry, I'm a hospital pharmacist by trade. So a lot of my discussions and points would be, I guess, relating to implementation of an AMS program in the hospital setting. So antimicrobial management and stewardship programs have been developed in hospitals in response to the need to reduce unnecessary and inappropriate antimicrobial use. And AMS is part of a broader system for infection prevention and control to minimize resistance. And stewardship means to protect something. So antimicrobial stewardship it's about optimizing how we prescribe and use antimicrobials by taking into account the evidence of efficacy for these antimicrobial agents, its toxicity, and also its impact on ecological harm. So when we use and prescribe antimicrobial, what will be its effect on resistance and development of C. diff infections and toxicity? And we do all this really to achieve 2 key goals. First is to improve patient outcomes and patient safety. So, for each patient who's prescribed an antimicrobial, we want to make sure that they achieve the best clinical outcomes, and also to reduce antimicrobial resistance. And an AMS program alone is not sufficient on itself program alone is not sufficient on itself to control resistance. So to be effective, the program needs to be established in conjunction with a comprehensive infection prevention and control program that includes hand hygiene, standard and transmission-based precautions, and cleaning and disinfection. Next slide, please. Okay. So to run an effective AMS program in hospitals, we need to have, very strong, solid foundations and building blocks to build our processes, and then, and eventually evaluate our program outcomes from there. So this slide shows basically the building blocks. So at the very bottom of the foundation blocks, you need to have, clear organizational structures and governance. So a successful antimicrobial stewardship program requires executive support and clinical leadership, as well as teamwork between prescribers, pharmacists, and nurses. And we also need to have a Antimicrobial Stewardship Advisory Committee, which will be the overarching governance of the AMS program and its initiatives. And this committee usually consists of a multidisciplinary clinical AMS team who have expert knowledge and advice, and they consist of infectious diseases experts, microbiologists, pharmacists, and also stakeholders that you want to engage in the stewardship program. So they could be physicians from respiratory, surgical, and even infection control nurses and consumers. And then you need to have, good governance. So hospital administrators and executives that provide explicit public and unequivocal support and support to provide the resources that you need, and also to be available for timely, effective dispute resolution. And also you need the staff in the AMS program to implement the initiatives and services. So as I mentioned before, the pharmacists, the infectious diseases and microbiologists, and also you need, make friends with people in the IT department, especially if you've got electronic medication management systems in your hospitals. And the IT framework itself, so the programs that you run, they must facilitate efficient work processes to support the program and the processes of the AMS program, and to enable clinicians to do the right thing, whether it's getting approvals for restricted antimicrobials or decision support tools. And then we look at the processes. So you need to also implement good processes for the program. So the processes would be the essential elements of the AMS program, which includes the use of treatment guidelines that take into account the local microbiology susceptible patterns, selective reporting of susceptibility testing consistent with your hospital treatment guidelines, and reviewing prescribing with intervention feedback. And as Katia has mentioned in her earlier presentation, education is very important to the senior clinicians, to the medical officers, so your junior doctors, the pharmacists, nurses, students, even consumers. So education training is important. And in terms of, at the very end, so you've got the structures and foundations, you've got the processes, you've got education, and you need to know whether the program is working well and if they're achieving the outcomes and the goals of your program. So that's where you have outcome measures to determine the efficacy of the program. So that we're looking at, your resistance rates or C. diff rates, whether your antibiotics are being used appropriately. So looking at how much antibiotics you use and how well you use it, and also, the reception and the acceptance and prescriber attitudes to the AMS program itself. And these are the strategies that are used to measure the outcomes. So clinicians may be audited on prescribing adherence to local national guidelines, appropriateness for individual patients, and quality of intravenous to oral switch, and clear documentation plans for review. Next slide, please. So in Australia, the National Safety and Quality Health Service Standards mandate that all hospital organisations must have an AMS program in place with our policies and clinical resources and governing structures within the hospital to support quality use of antimicrobials. So this falls under the overarching prevention and controlling infection standards, also known as Standard 3 in Australian hospitals. And the AMS program within each hospital in Australia will act in accordance with the directives of the standard. and include the core elements, recommendations, and principles from the AMS clinical care standards. Next slide, please. So the AMS teams, each hospital with an AMS program, the AMS team rely heavily on data to inform the direction of the program and the strategic priorities of the local program. So in Australia, we have two national surveillance programs. So the first is NOSP, or National Antimicrobial Utilization Surveillance Program. So basically with NOSP, we're looking at how much antibiotics we use in our hospitals. So it's an ongoing benchmarking data set where the tonnage of our antibiotics converted to defined daily dosage per patient bed days, and our performance of the antibiotics we use. Mainly we look at broad spectrum antibiotics like your third generation cephalosporins, your carbapenems, fluoroquinolones, and they're benchmarked against hospitals which are similar to us, and it allows tracking of progress over time. So looking at whether we're using more or less of the antibiotic, gives us an idea of the performance of the AMS program, but also it doesn't tell you about the quality of the prescribing of the antibiotic. So we may be using a lot of it, but it doesn't tell us whether we're using it well, or whether it was appropriate or not. So that's why we also contribute data to the hospital NAPS, which stands for National Antimicrobial Prescribing Survey. So it is this is a point prevalence hospital-wide point prevalence audit that every Australian hospital participates in, every hospital with AMS program. So the antimicrobial prescriptions are assessed for appropriateness, and appropriateness measured by how well the antibiotics are prescribed. So whether they follow guidelines, if the indication is appropriate, if it's the right route to a spectrum. And all of the hospitals with AMS programs who participate as contributors to NOSP and NAPS in Australia have agreed to have their local data contributing to our national passive surveillance system. Next slide, please. So there are several key strategies to implement the AMS program in the hospital. So I've divided them into pre-prescription, that's before antimicrobials being prescribed. So you can look at formulary management. So having an antibiotic formulary that includes restricting broad spectrum antibiotics like third generation cephalosporins and carbapenems to patients in whom the use is clinically justified. And also having specific guidelines, taking into account the local antibiograms and susceptibility patterns and resistant patterns, and lab stewardship, so selective reporting and susceptibility testing, so to nudge prescribers into good prescribing behavior. And confirming patients' allergy status is also important. There's a lot of research done in the last 2 years, particularly by our Melbourne colleagues, Dr. Jason Tribbiano, around allergy testing and delabeling as a stewardship initiative. And the post-prescriptions space, we do audit and feedback rounds. So we look at prescriptions and then we provide feedback to the teams. We do AMS ward rounds. And I've mentioned before, we monitor appropriateness using NAPS and monitor our usage using NOSP. And also because a lot of hospitals in developed countries have moved to electronic prescribing systems. So we're looking at digital innovation. So looking at finessing the tools on electronic prescribing software, providing clinical decision support or clinical care bundles to enable prescribers to prescribe the right antibiotic for the right indication, having live dashboards to facilitate auditing and rapid cycle auditing and automatic stops. And also IV to oral switch, when patients are on IV antibiotics, intravenous antibiotics, facilitating oral switch to reduce the risk of line infections and facilitate timely discharge home. And antimicrobial therapeutic drug monitoring is something that is heavily advocated, definitely in Australia and in developed countries, because there's no one size fits all. And we know that the standard dosing doesn't apply for patients who have augmented renal clearance in a critical care setting or obese population. And This is the end of my slide. So in terms of challenges moving forward, I think in terms of capturing outcomes, resourcing is always still a problem, I feel, particularly even in developed countries. So convincing executives to provide more resourcing and support for AMS programs. And I think one of the gaps we could bridge moving forward is looking at, working on a good model of economic evaluation to capture whether AMS programs are are cost effective, and also they provide value for money or value-based care to our patients in society. So this is the end of my presentation, and I will pass on the floor to Mervyn. Thank you.
Thank you so much. My name is Mervyn Mpundu. I'm the director of REACT Africa, and I'm also the engagement and partnership lead for the International Center for Antimicrobial Resistance ICAS solutions, ICAS. What I'm going to focus on is I'll try to draw some experiences that are in the African region. And when we talk about actually stewardship, we've been given some examples and some great principles and great interventions. And I'll try to draw some parallels and try to show what we can do. I mean, whether we should even bother to do, stewardship in low and middle income countries. And I'll be able to say that, low and middle income countries, we tend to put them in one bucket, but I'll use it loosely just for the sake of this presentation. There are a number of challenges in implementing AMS programs in our settings, whether one is really in Africa, Asia, or Latin America. There are challenges that begin with the basic understanding of stewardship. The definitions of stewardship, the lack of national policies that support and promote really antimicrobial stewardship, lack of really buy-in by the leadership in countries, lack of data that can be used. Both surveillance here, looking at microbiology and looking at actually consumption. Very few health institutions do antibiograms and that guide guidelines. We've got lack of and weak microbiological data, because most patients who should be cultured, for example, at the time of presenting into the ER when they are admitted, do not get tested. And we don't collect those samples, and there are many reasons. Weak lab infrastructure, lack of the consumables, lack of the capacity and also the capabilities of doing certain ASTs and also other bacteriology tests that would actually inform and move us from empiric therapy into directed therapy. Most of the hospitals are challenged with really poor IPCs, and you find that a number of institutions do not have any running water, for instance, and so that compromises any gains that you're trying to make in stewardship. And I think the fact also that we have one major problem, which is chronic stockouts in most of the hospitals. Most of the public hospitals get their supply of medicines, including antibiotics, primarily through a central procurement agency. And most of the countries that we have worked on, I've spent the last 10 to 15 years working on issues of stewardship, on issues of developing guidelines, building capacity in African countries in terms of actually addressing this area of AMR by using good stewardship programs. And you find that in a lot of places, there's no running water. The charts, for example, most of them are paper charts, and it's very difficult to do really any prospective audits when you have to look at 4 different documentation and that are not actually aligning. Next slide. So there is we have a situation where there is actually overuse and underuse and misuse of antibiotics, which are the primary drivers in the region. But not only that, we have, one of the fundamental problems that we have is that there are more people actually in low and middle income countries that die from lack of access than access itself. And when one is looking at the cornerstones or the pillars of stewardship, some fundamentals need to be in place. We're looking at really having a functional lab that can be able to actually test and, where we can do the ASTs. We should have a pharmacy that is well stocked and, is not challenged in terms of what is available, and so that we have the right antibiotics at the right time. But also we have, the challenges that human resource capacity and financial resource capacity are the 2 major areas that are really a hindrance in having a successful stewardship program in our region. Well, WHO and other organizations like REACT have developed a number of toolkits that can help an institution that does not have that A team of having a microbiologist in the hospital, of having a clinical pharmacist, having, these fundamental resources that we take for granted in the West. Some countries have only got 1 ID physician or 2 ID physicians. And so how do you actually, can you really implement stewardship under these constraints? So there are tools that are there. I believe that, yes, we can. We can implement stewardship by looking at some areas that we can improve on. For example, most of the common areas that we can improve in antibiotic prescribing, include just having some guidelines in a hospital setting. Most hospital settings that I've been to in many countries, the institutions do not have any guidelines really to guide. And so really prescribers just prescribe anything that they're going to prescribe. There's over-prescribing. There's the overuse of actually broad-spectrum antibiotics. That unnecessary use of fixed dose combinations like ampicillin and cloxacillin that have got no clinical advantage at all. Wrong dosage is so common, wrong dose intervals, wrong routes, wrong duration, and delayed administration. I've seen patient charts where really patients have been on antibiotics for over 20 days and nobody picked it up, not the physician seeing the patient, not the nurse, not the pharmacist. Next slide. And so you have these sort of actually inherent problems. But like I said, we can actually implement stewardship programs from the lowest level of a healthcare facility up to the highest level, where we've got actually trained clinical pharmacists, but also not forgetting really the communities. This is one project that we just did in Kenya last year, and we've continued this year in really establishing antimicrobial stewardship programs in Kenya. And fundamentally, some of the things that you would have to do would be to get into some actually formal relationships with the ministers of health, where you do your baseline studies, you do your PPS studies, and present that data to get the buy-in into the programs and to make a case for investment in stewardship. And so there you see, that's the Minister of Health. We are just signed up to the MOU, and I just presented, the findings that we found, really wanting in the institutions, as I said just about a minute ago. Next slide. And so really having the government involved is really, really critical, and it is important. as I argue, I think AMS programs can be implemented. There are a number of studies that have shown that you can just take 1 or 2 interventions at a time, and you can be able to be successful in implementing. For example, there have been studies in South Africa, there have been studies, in Egypt, where just really having one intervention of converting from IV to PO, there have been savings over 40% of what these institutions have been actually spending. And so you can actually see that. This is one of the studies that actually looked at these programs in Africa and how difficult it is. But it also found out that, you can actually successfully really introduce stewardship by taking some of the interventions that might not need microbiology, for example. If you're using real empiric therapy, ensuring that there is compliance, ensuring that we are doing the prospective audits and feeding back into the prescribers and into the hospital itself, so it can make the necessary decisions. Next slide. So when one looks at it, is that, you have this sort of a challenge. And once you focus on those, like I started really with that slide, that gives you, a stark and scary picture that, you've got no human resources, no labs, talk out of medicines, there are no guidelines. It becomes really, really daunting. But we have seen a number of health institutions in the African region try to, really implement and start to work on stewardship. Last week I was in Tanzania, for example, where we conducted actually training and also did a point prevalence study, and those actually results now get to feed into the interventions. So some of the strategies that can work, it's both the bottom-up approach. I mean, at the national level, AMS developing a policy that guides and requires, stewardship should be something that is actually developed and made sure that, every hospital, retailers, pharmacists, in every actually practice have this level of understanding, and also having the quality measurements that can be used, ensuring that resources are mobilized for really investing, in the infrastructure, but also ensuring that, we build confidence in the lab results that come out, because often even institutions that have got the capabilities and capacity of doing labs to guide the choice for the right antibiotic, sometimes the clinicians don't believe those results, and they just say, I don't trust the lab, and so I'm going to give anything. One area that we need to focus more really as pharmacists, it's there's been a change in the first point of care in the health system, that the pharmacies and drugstores have become the first point of care. And unfortunately, in this region, you can buy any antibiotics without a prescription in most countries, and you can buy from the market. And I think community pharmacists are really left out, and some of them, they claim that they make more money from really selling these antibiotics because we are in the sub-Saharan Africa where we've got the highest levels of infectious diseases, and so there's that sort of a tension between them. Should I sell? Should I not? What's the right thing for me to do? And I think professional bodies also have a role to play. And I think, we can actually tackle these issues by really integrating, national programs, national policies, and strengthening regulation, for example, regulators, ensuring that, the pharmacy associations have got a buy-in, and ensuring that, we all get engaged, and we just take 1 or 2 interventions at a time, probably just looking at overprescribing, probably just ensuring that we are de-escalating, probably just to convert from IV to PO those are few interventions that really one can do. But of course, there are challenges, and we need to really work towards getting the buy-in from, not just, clinicians, but the management that hold the check, because that's where the rubber hits the road. And so, this is my last slide, and just to really say that, we can do stewardship, not at the same level like well-resourced, countries and institutions, but nevertheless, from the lowest level of care, and we as pharmacists have got an integral role to play. Thank you.
Thank you. Thank you, Merfin M. Kudo, for the experience on AMR program in Africa, and also for Chin Yen Yo, AMR program from hospital in Australia. Our last speaker will introduce the side element. Let Dara to go on.
Hello, everyone. So can you hear me?
Yes, I hear you.
Okay. Thank you, Virat, for the introduction. And I'd also like to thank the FIP, specifically the FIP AMR Commission, for inviting me. It's a pleasure to be with you here. And actually, as pharmacists, it's one of the favorite tasks we do to the profession is to promote against antimicrobial resistance in the last week of November during the World Antimicrobial Awareness Week, as every year. So it's a pleasure to discuss with you today the science element, which pertains to the Developmental Goal 17 about antimicrobial stewardship. So after the colleagues have discussed the workforce and education backgrounds, as well as the practice in a very nice presentation from Australia and from the low and middle income countries, I would like now to discuss a bit the science element of DG17. So we will start this in the next slide. The FIP promotes the science element of antimicrobial stewardship through promoting research and development. This involves new antimicrobials, antimicrobial combinations, and also ways to promote and advance antimicrobial stewardship in practice settings. So this will focus on mitigating the evolution of antimicrobial resistance, which is becoming very common, to report also the data that are available regarding the relevance and the importance of antimicrobial resistance and how the stewardship programs can be properly implemented, and also to raise awareness about this topic to the pharmaceutical sciences companies as well as to the public, and also to promote new strategies for development of new agents. So what does the science say regarding antimicrobial resistance? We will go over this in the next slide. So actually, maybe many of us have seen this representation of the extrapolated numbers of deaths regarding antimicrobial resistance. So antimicrobial resistance today claims the lives of over 700,000 people every year, which is almost half of the number of deaths from traffic accidents. It is estimated that if there is no breakthrough in the development of new antibiotics and in the mitigation of antimicrobial resistance, these numbers are expected to escalate to about 10 million deaths per year in the year 2050, and also to losses of trillions of dollars in the economy, and also a global, a very high global economic burden. Whether or not these numbers or these estimates are correct, it is of course important to mention that the growth of antimicrobial resistance and what science does tell us about this problem is very important in order to have consolidated efforts so that scientists all over the world, as well as health practitioners, including pharmacists, have an interdisciplinary action in order to control this problem. Perhaps one of the hidden problems that have occurred in the shadows of the COVID-19 pandemic is also an escalation and a flourishing of the antimicrobial resistance as a result of the use of biocides and antiseptics, as a result of empirical therapy with antibiotics to COVID-19 hospitalized patients, as a result also of the reduced care for many other routine conditions. So we have seen also that this problem has been escalated and remains one of the dark sides of the pandemic that have not been yet adequately addressed. with a very high number of patients with COVID-19 admitted to hospitals receiving early empirical antimicrobial therapy, although many of them did not necessarily need such treatments. So what else does science have to say? Can we move on, please, to the next slide? This is a listing of the WHO priority pathogens. According to literature, these are the priority pathogens towards which the WHO, according to the list of the 2017, has required research and development in order to obtain new antibiotics. So you can see the critical priority are mainly the carbapenem-resistant gram-negative bacteria, which are very well known in nosocomial settings. The high priority includes others such as the Enterococcus, the Staphylococcus aureus, especially the MRSA, as well as strains of Helicobacter pylori, Campylobacter, and newly also Salmonella strains that have been identified as high pathogens, whereas the last priority, or priority 3, includes the penicillin non-susceptible strains of Streptococcus pneumoniae, the ampicillin-resistant Haemophilus influenza, and the fluoroquinolone-resistant Shigella. Those of us who work in hospital settings are very aware and well acquainted with the escalation of numbers of these microbes. Those of us who work in research also have noticed the escalation of the number of papers addressing these microbes and the need, or the urgent need, to take an action in order to avoid further progress of these critical high and medium priority pathogens. So let me focus a bit on how the FIP have addressed the global efforts in order to mitigate antimicrobial stewardship with the help of science. Next slide. If you can see in this slide, the 2017 statement of policy by the FIP on the control of AMR, which indicates the commitment of FIP to align with the different efforts in controlling the problem of antimicrobial resistance. So if you read within the statement of policy, you will find that FIP has advocated for the support of those working in settings that need additional antimicrobial stewardship, has also supported the discovery and the development of new cost-effective medicines to treat infections, has promoted evidence-based medicine in order to avoid the haphazard or the irregular use or the misuse of antibiotics, and preserve these drugs which were once thought to be miracle drugs, but unfortunately we are losing many of them step by step. Also, the FIP statement of policy advocates to conduct and translate research on all aspects of AMR, and how the different research, or how can we use the science elements we know about AMR to transfer these elements into the bedside and to make them help in the optimal management of patients. And of course, the FIP statement of policy encourages the discovery and the development of new antibiotics, as well as the advocacy towards the use of vaccines, because as we know, an increase in vaccine utilization will reduce infections and thereby will reduce the flourishing of antimicrobial resistance. Additional efforts of the FIP are also shown in the next slide. So actually, FIP has partnered with the WHO in the Global Action Plan that has been launched in the year 2015. The objective of this Global Action Plan was to make sure that antibiotics remain available as quality medicines, remain effective, the resistance rates are a bit controlled, and also remain accessible to all those who use them. In order to remain aligned, or to have the same language and be on the same spectrum with such global efforts, the FIP has also supported this, the development of this action plan. And if you read within this action plan, you will find that the strategic objective 2 is deeply rooted into science, where it advocates for strengthening the knowledge and evidence-based approach in order to mitigate the antimicrobial resistance and do more surveillance on resistant microbes, and also more research. So this research will have the effect of knowing the incidence and the prevalence of resistant pathogens so that we can target them, understand the development of resistance and how it circulates, because circulation of resistance today is not limited to humans, but also we can see it in the environment, in water, in the food chain, and even in the animal husbandry, and also to improve the tools for surveillance and diagnosis of antimicrobial resistance, and to improve multiple aspects of research. When we say research or science, it does not mean only the development of resistance, but also the research on the social and the economic impact of antimicrobial resistance. Next slide, please. How can advance in science or progress in science help us in mitigating AMR? We can see on this slide several aspects of this. So for example, science can help us to designate the spread of resistance and identify the key areas or identify the hotspots where resistance exists, as you can see in the first map. Science can also help us to carry on more and more clinical trials in order to be aware of the best way to utilize and promote the use of antimicrobials in patients. Science can also give us insights into the circulation of antimicrobial resistance in animals. So after their successful use in humans, today the animal husbandry and the food chain have been very commonly interrupted by antibiotics. So science does help us to see how is resistance spreading not only within humans, but in the environment as well. Science may also have a very, very important function in explaining the mechanisms by which the superbugs develop resistance. So literature today has investigated and has elucidated numerous complex mechanisms for the development of resistance, and further progress in science is expected to find very, very new and even micro pathways that allow us to understand how resistance is developing and how the multi-drug resistant bacteria are continuing to thrive despite high doses and multiple mixtures of antibiotics. Lastly, science may also help us to follow up antimicrobial resistance by designating the useful breakpoints or the useful minimum inhibitory concentrations for the use of the important antibiotics, so that in our laboratory investigations, the scientific guidelines can also be there to help us identify where does the resistance exist, what are the guidelines above or below which we can consider our microbes resistant or sensitive, and how can we make use of this in order to understand resistance more and to delve deeper into how can we make use of these numbers so that we mitigate the spread of resistance. Next slide. So actually, over the past few years, we know that the antibiotic pipeline has been almost a dry one. We all know that more than half a century ago, the golden age of antimicrobials flourished, with large number of antibiotics being exposed and being used clinically. Also, and unfortunately, after this initial surge in the development of antimicrobial substances, many multi-drug resistant bacteria have been discovered. And for like 10 years or so, we have not seen a real change in the mechanisms of action or in the development of new antibiotics. So actually, yes, we did have a dry pipeline, and perhaps this has allowed the different multi-drug resistant bacteria to further thrive and to develop selection pressures against the available antimicrobial agents. So I would like to finish this on a good note. Does science indicate to us that this pipeline will change, or do we expect over the next coming decades that there is a change in this picture? And is there any are there any findings that tell us that we can mitigate antimicrobial resistance and we as pharmacists can contribute to helping this problem? Actually, I would like to share with you in the next slide a review about the future of antimicrobial resistance with the development of new agents. So actually, always we focus on science, and science does indicate that the future of AMR is expected to change if we put more effort, if we put more focus, and if we give more funding for the development of new antimicrobial substances. In a research paper very recently launched, over 400 preclinical projects focusing on new antibiotics or antimicrobial mechanisms have been described. And most of these actually come from the SMEs, small and medium-sized enterprises, in addition to smaller number coming from big institutions and laboratories. So actually, if you go over this review, you will find that many interesting approaches are being done. So there are interesting approaches towards virulence of bacteria. There are also interesting approaches towards being more specific or pathogen specific. There is focus on the use of non-traditional therapies. There is a leap back towards the focus on bacteriophages, which may also have a role in the mitigation of AMR if we clinically develop them well. There is also a focus on small directly acting molecules. There is a focus on immune modulators. And as we've seen with COVID-19, there is a focus also on repurposed drugs. And there is some insights also into new agents that can inhibit the virulence of multi-resistant drug pathogens. So actually, the focus should continue, and perhaps it will be mainly on gram-negative bacteria. And if this focus continues and with additional funding, we expect that the future of AMR should have a breakthrough or should have a change expected over the next decade. With this, I finish, and thank you so much.
Thank you very much, Dr. Dara Hamoudi, for the focus on side of antimicrobial stewardship. The time is go very fast, and we will start Q&A. May Ayo Deji, do you want to start the question? Okay.
So our first question, we have a question from Professor Sabia Esak to Katia. So she's asking, is the WHO competency framework and proposed curriculum appropriate for pharmacy? Does it require extensive adaptation?
Thank you. Thank you very much for this question. Sabira, it's a great honor to be here and to have you assisting on this lead. This WH, it's quite useful to establish a curriculum basis, the basis of the curriculum for pharmacy. About your question that if required extensive adaptation, I think that not require extensive adaptation, because it's very useful and it's very concrete, the competencies that this document attributes to the pharmacists. I consider that we should aim to have a broader document that also can include, for instance, online and free available tools in order to help the pharmacists to implement their own programs. And for instance, I can talk about the eBug project, the UK project, that have available the documents that we can use, for instance, promote the disease infection prevention on schools. So of course this document is very useful, but I think that we can have a document with tools and to best practice included. Thank you.
Thank you. There are a lot of questions in the Q&A box. The next question is for Dr. Mundo. Dr. Mundo Murphy. The question is, are unstable supply chains and stockouts compromising AMS in low and middle income countries? What can be done? Murphy, Mundo.
Yes, if I had the question right, the question
yes.
is about what we can do about stockouts.
Yes,
is that correct?
Yes.
So that's a very critical and important question, because you know, when we're looking at access, ultimately we're trying to look at how we can make these antibiotics available at the right time in the right quantities, and also, you know, looking that, I mean, it's given. in the right frequency. I think one of the challenges that we've had is that, the pipeline for antibiotics has been quite dry, really. There's no investment that is going on. And since 1978, as you know, there haven't been any new classes of antibiotics. African countries, for example, in East Africa, the largest manufacturers of antibiotics are in Nairobi, and there are only actually 6 that produce beta-lactams, and those are just ampicillin and cloxacillin, and that combination. We have to continue investing and strengthening really our systems. We have to train in procurement, address the procurement cycle. We have to find a way in which we can really kickstart and increase local manufacturing, because like what we have seen in the COVID era is that, most countries in the region depend on 80% of their medicines are imported into the country, and only 20% or less is actually manufactured locally. And most of the African countries don't even have a pharmaceutical industry, and so they depend 100%. So if there's any disruption in supply chain, then a lot of things are disrupted. So I think it's very important that we really focus and try to look at ways in which we can promote really antibiotic production and supply, but also other molecules. Unfortunately, the current market incentives for the pharmaceutical industry is volume-based for profit. And so, the lower-income countries are not going to give you so much profit. And so you go into the higher markets that are more profitable. Yeah, but I think it's a tough question, but we need to actually address it at many fronts, and being able to decouple, the volume-driven incentives that are misaligned. Thank you.
Thank you, Murphy Monrudo. The next question is for Dr. Hamodi. Dr. Hamodi, the question is, in your opinions, should R&D focus on preventives, such as the vaccine, as opposed to the therapeutic, such as the new antibiotic or new combinations? Preventing infection reduce the need for antimicrobials and subsequent selection picture for AMR.
Thank you for the question. Actually, I see that these two approaches should be complementary rather than opposing. So I think that from now until our pipeline becomes rich again, we have to focus on the R&D of new antimicrobial substances, and this is what is currently being done. However, I believe that meanwhile, it is very important that we stress on vaccination, prophylaxis, preventive and hygiene measures in order to try to reduce the burden of infections as much as possible, and this will also reduce the escalation of resistance. So actually for me, the two approaches are not opposing, but I see them complementary, and both of them are needed, are much needed. Thank you.
Thank you. And the next question is maybe the last question. It's for every speaker. If you want to respond, you can. The answer is, what is your opinion on antimicrobials in the development and their role as a trigger for new resistance in the development? Do you think that degradable antimicrobials might be a solution? Which one want to respond to this question? Which one want to respond to this question about the antimicrobials in the development? It will like okay.
About antimicrobials in the environment. As Dr. Dalal mentioned, the environment is a hotspot of antimicrobial resistance, not only to acquire, but also to disseminate to humans. And the WHO has stated creating the One Health statement to share awareness to all of us that we have to increase our thoughts about the impact of the environment, not only at the antibiotics that should be sent to the pharmacy after their use, or as Dr. Murphy mentioned, the challenge of to have the destruction of the antibiotics, but also, for instance, in wastewater, the wastewater of the hospitals, also the companion animals. It's a new area of knowledge, and we need to, on food, as Dr. Dalal also mentioned. So we need to know more about the environment impact, and to promote actions to prevent those dissemination. But in my opinion, we already know a lot about the human impact of antibiotics. So we have to focus on the measures that in our environment, has hospital pharmacists, community pharmacists, veterinary pharmacists, we can implement in order to reduce or to optimize the antibiotic use.
Yeah, just to add on, I think we know, I think at least we know enough that there is a lot of pollution, there is a lot of really spillage, there's a lot of actually, many antibiotics, they actually end up in the environment in many ways. I think I'll just mention two primary ways. For example, when you are in African countries, maybe South Africa may be different, a little different, but really there is nothing the way we see what is like in the northern countries, in the US, where really a patient can return unused medicines to any pharmacy. And at least, we are trained on proper disposal. So you look at the communities, because a lot of antibiotic use is happening in the communities and not in a controlled environment like a hospital. So if really, what is left gets into the environment, they get into the agro systems, and there is little regulation and no regulation sometimes for the pharmaceutical industry in terms of effluents that come out of those pipelines. And so this is critical, that we need to really be having these conversations. We need to be advocating. We need to be lobbying to ensure that we can dispose of, and they can be, limits and standards that address, how basically what is remaining in the pharmaceutical pipelines, where they end up. In most of our countries, that doesn't happen. Now, some regulations may occur, but nobody cares about it. And so really the environment is huge. And I think we need to also approach it as a One Health issue, because there is a lot of overuse and abuse of antibiotics in the animal sector. And again, there they end up into the environment. And so we really have to approach this as a One Health issue and ensure that we really reduce and limit this sort of actually pollution, or this disposal that is being done and contributing to drug resistant genes and AMR itself. Thank you.
Thank you. I'm agree with Murphy, M. Budo, and Katia. The time is go fast. May I give for the next section, give the floor to the Christopher John from FIP.
Thank you so much, Virat, and hello everyone. I'm going to talk very briefly about monitoring and evaluating Development Goal 17, Antimicrobial Stewardship. Please do stay tuned. Please stay with us. We've got an activity view, a very brief activity view to take part in. But I'm really going to talk about monitoring and evaluation of this development goal via the Global Pharmaceutical Observatory. Next slide, please. Very briefly, the Global Pharmaceutical Observatory's mission centers around data, intelligence, advocacy, and reporting. We know the importance of data. The pandemic has made that very important, and it's equally important for antimicrobial stewardship, antimicrobial resistance. And the importance of this data is for us to provide us with evidence, and for evidence to provide us with intelligence. So our first task is always to collate valid global data on workforce, education, practice, and pharmaceutical science elements of this development goal. We must undertake comprehensive analyses of collated data to provide accessible, high-quality intelligence, and all this must be communicated innovatively to promote our member organisations' impact on health. Next slide, please. You'll see on the screen now the outputs and inferences of the GPO. I won't go through all of these, but sharing and disseminating intelligence will inform policy formation and advocate for the profession that can equally be applied to antimicrobial stewardship, right through down to health system strengthening by tracking progress against the development goals and this particular development goal. And that's why we're all here today. Next slide, please. So current GPO actions and projects, again, I won't go through all of these, but at the bottom you see we are developing development goal indicators so we can monitor and evaluate progress against the development goals. And today what we want to do is seek your views on how we monitor progress towards development goal 17. So next slide, please. So this is the short engagement activity. FIP is now seeking to develop indicators and country-level metrics to measure and monitor progress and the performance of the implementation of the FIP development goals. Today, we're looking at FIP development goal 17. So now we'd like you to just either scan the QR code or click on the link, as we're seeking your support for this global indicators and metrics project. And we would love it if you can contribute to this brief activity, link to this event. And we'd like to know your opinions about how this development goal, antimicrobial stewardship, can be monitored and measured. You'll also receive an email to complete this activity after the event if you don't complete it in the event. But as I say, if you could do it right now, that would be great, as it only takes a short time to do. There's also a link in the chat box, which I will recirculate again now, which you can click on and give us your views. Thank you so much. We'd be really, really grateful to hear from you on how we can measure progress towards this very important development goal. Thanks, everyone.
Next slide, please. Thank you, Christopher. Thank you, Ayodeji, Katia, Chin Yen from Australia, Murphin from Africa, and Dr. Dalan from Lebanese. And also, I would like to invite participants to the next episodes. Ayodeji, you want to give the short message to our participants before finish this session?
Thank you very much to all our attendees for engaging with us during this webinar, and we hope to see you in the future events for each region. So the AMR Commission is hosting events for each region, and you can register at the link in the chat box, or just go to events.fip.org and search for the digital calendar, and hope to see you. Thank you.
Thank you. See you in the next session. Bye-bye, everyone. See you next episode. Bye-bye.
Bye.
Bye. The nice day for everyone.